All right, we will start. Hello, everyone, and thank you on behalf of eSport Lebanon chapter. Thank you for everyone who already joined the webinar. I'm Wadi Amina, the president of the chapter for the years 2026 and 2027. For those who are joining an activity or an event that is organized by eSport for the first time, who is eSport? eSport is the Professional Society for Health Economics and Outcomes Research. It's a global society. We are the local chapter, we're eSport Lebanon chapter. The society's mission is to increase the reliance on HEOR tools in order to inform decision making and in order to eventually optimize patients' outcomes. When we talk about health economics, we don't just mean cost effectiveness studies and budget impact analysis. It's a very wide field. We rather mean health economics as a social science that looks into choices and incentives of individuals, providers, and policymakers within the realm of healthcare. So the local chapter is doing its best to bring closer these tools to our problems, to our realities. And for the years 2026 and 2027, our focus will be mainly on four priorities. First, we will expand our reach. If you are interested in HEOR, if you would like to be part of eSport, to contribute, please feel free to reach to us on this email. We will also focus on the priorities that are relevant to Lebanon. We will focus on doing training for our chapter members, for the public sector, trainings related to HEOR. And finally, we'll be supporting research in the HEOR field, be it in Lebanon or in the region. So the board that will focus on driving these priorities forward for the next 2 years is formed of myself, Dr. Rita Taslim, who's the president-elect, Dr. Walid Hallaso, who's the secretary, Mr. Maher Hassoun, who's the communications lead, Dr. Basima Hazime, who is the treasurer, and Dr. Firass Abiad, who's the past president. So for today, we have a very busy agenda. I want to thank the speakers and the panelists, His Excellency Dr. Abiad, Dr. Shajib Hussain, Dr. Ibrahim Bouram, Dr. Bilal Abdullah, who's going to join the panel discussion from the Parliament, and also a big thank you to Dr. Nadine, who's not only a speaker, but who's also helping us and shaping our activities and being more impactful. So I pass the word to Mr. Maher Hassoun, who's going to introduce the first session. Mr. Maher Hassoun, our communications lead.
Hello, everybody. First of all, let me thank you for your attendance today. So our first speaker is His Excellency Dr. Firass Abiad, a Lebanese surgeon and health system leader with more than a decade of public sector experience. He served as a Minister of Public Health of Lebanon from 2021 to 2025, a tenure defined by navigating compounded crises and translating urgencies into institutional reform. His Excellency also focus areas including health governance, access to care for vulnerable populations, universal health coverage, digital health, and climate-related health risks. His Excellency currently teaches at the AUB and is the author of a recently published book reflecting on decade of health crisis in Lebanon, with an English translation forthcoming. His Excellency Dr. Firass Abiad, the floor is yours.
Thank you. I'd like to first thank eSport and all the colleagues and friends really for the invitation to address what is currently, I think, one of the biggest challenges to our health system, namely the displacement of around 1/4 of our population, around 1.2 million individuals also at a time when our health system is facing several other crises, including the casualties and direct targeting of health personnel, institutions, and first responders. So my talk is going to be about displacement and how can we maintain good health outcomes when we are faced with a mass displacement. And here, the crux of my talk is going to focus on the idea that preserving health outcomes during this mass displacement means preserving continuous access and utilization. Because if there is availability without utilization, it will not allow you to reach what you want, which is maintaining good health outcomes in your system. So before I move into how we're going to do that, what we need to do is to understand how displacement affects the health system. And here I want to touch upon 4 important points, I think, that play a major role in differentiating between the health system during displacement and the health system during times of peace. The first one relates to the fact that in times of peace, the health system is very much fixed point access oriented. What I mean fixed point, meaning that a lot of the services that are given in the health system occur at fixed points, either at, for example, a fixed PHC, a fixed hospital, other fixed points that patient can resort to. But when we have displacement, the patient moves, and a lot of the time it is moving away from these fixed points. And this movement, this sometimes continuous mobility, moving more than once during the displacement, means that it interrupts a lot the continuity of care and the access to care. The second point, which is important during displacement, especially displacement during conflict, during war, is that health might not still be the highest priority for the individual, because now they are talking about safety, they are talking about events that can really be an issue of life and death. And therefore, some of the regular health practices, vaccination, going and doing a primary checkup, if they notice, for example, a lump somewhere, all of these things the priority of doing that changes, because people will say, okay, I will postpone this because this is not urgent. Now what is urgent is for me to feed my children, for me to access clean water, and so on. And this means also the change in prioritization affects the financial status, because a lot of the time when people are displaced, it means their access to work is interrupted, their access to resources, they utilize their savings. And that means, especially in a system where we have a high level of out-of-pocket payments, it means that, what they do with this very small amount of cash they have can also have an impact on how they prioritize their access to care. The third element, which is important, is that we see a change in the disease risk and categorization. So, for example, a lot of, if you look at Lebanon during the time of quiet, during the time of peace, certain communicable diseases were very rare. Cholera, we only saw it after mass displacement and from the Syrian crisis. During the last war in shelters, we saw diseases that were not common, like scabies and other diseases, communicable diseases, mainly because of the crowdedness and so on. So suddenly the circumstances change, and then certain disease patterns change as well. Also, the percentage of acute versus chronic illnesses, where in displacement, because people delay presentations, it means that you will see diseases in their more advanced phases, or in a more acute setting where people will only present to the emergency room when really the situation gets bad. So all of these mean that the situation during displacement can be very much different than the health system that during time of peace. Now, when the war in 2024 started, the ministry decided that it's going to approach that crisis in a different way. And, one of the first decisions that we took at the ministry is that we are going to be proactive rather than reactive. So instead of waiting for the crisis to occur, we said we want to start anticipating what could happen. We looked at the 2006 war and we said we're going to work on that. And we identified that there's going to be an issue with casualties, and therefore we prepared for that with mass casualties training and coordination between hospitals, and all of that we saw it when we had the Pager's explosion. And also we started preparing for displacement and what could happen there, and this was an effort led by Dr. Hilal, who will speak after me. And we started simulating what could happen with, what could happen. Because really, we don't have a playbook, to use concerning these displacements. And there always events can change and new events can occur. For example, like when we had the cholera outbreak first time in 33 years in the year 2022. So the third thing that was clear was that we are working in a low resource environment. And that means we needed to optimize the use of available resources. Now, this is extremely important. And by the way, if you look at the available resources now in the war that we are fighting now, compared to the war of 2024, we see that now we have even less resources than the previous war for various reasons. So here, the way we addressed it at the ministry is by doing two things. First of all, making sure that we have a good platform of coordination among all actors. This was the Public Health Emergency Operating Center, the FAOC, which allows us to bring all partners and to, as much as we can, align the use of resources, make sure that we don't have redundancies and so on. That was very important. And the second thing we did was the use of digitization. There, here the ministry had multiple digitization applications that were developed that were either used themselves or changed to fit our needs during the war. And we will talk a bit more about that. But what was important is digitization allows us to do two things. First, it will allow us to have full visibility about the existing resources. Full visibility means full utilization. It means you get to use everything that is available and on time. Compare that to what happened after the Beirut explosion, where because we didn't have full visibility, for example, on the medications arriving, on where they are placed, it meant that a lot of the help that came on that day, unfortunately, went expired, went unused, and that created a lot of bad perception for the handling of those resources then. The other thing that digitization allows you to do is to also see the needs and the gaps. And that means that you could better, when you ask for help, you could ask for the amounts or the material that is needed. And this indeed was what the ministry did when it was communicating with international donors, where we were giving them exactly what are the things that we need and what are the things that we do not need, and therefore to allow us to have full digitization. Now, using all of this, we were able to manage some of the crises that we have. And here, quickly, I want to go over 4 examples, just to allow you to understand, how these principles were put into use. The first one was dialysis. It was clear that, we were expecting with displacement, there will be a large number of displaced patients, dialysis patients. And these patients, we cannot interrupt their care. So it means that, that on the day that they move, within 1 to 2 days maximum, we have to make sure that there are places for them to continue their dialysis. And by simulation, by calculating the red zones where the displacement will happen, to the green zones where we will receive those displaced, we were able to contact those hospitals, make sure we put with them plans on surge capacity for their dialysis unit. For example, at Rafiq Hariri, we made a plan where we could increase the capacity by almost 100%. And that meant that when we had patients being displaced from hospitals in the south suburbs of Lebanon, we were able to accommodate them almost immediately at the Rafiq Hariri hospital. And this was done across Lebanon, where the displacement happens. The other one, for example, was cancer patients. As you know, cancer patients, when they moved, they needed to have continued access on their medication, whether they're oral or whether they're IV. Now here, because we had the MediTrack and the AMAN, which allowed us to identify each patient by patient, where each patient had a unique ID, we were able to, even when they moved, by the use of their unique ID, we were able to send them the medications to their new setup. And sometimes they would move more than once per month or 2 months, and we were still able to bring the medications to wherever they were displaced accurately, without any waste, without having people coming in on their behalf. We don't know who these people would have been or what would they have done with the medication. By the use of those digital applications, we were able to make sure that every patient of them had access to their medication. Now, the third example was about patients who were being followed up in primary healthcare centers, or even sometimes patients who weren't in PHCs, but they were displaced. And what we did here in the beginning of the war, we had a small pilot with UNICEF where we created 20 mobile clinics that were used to go towards, because people, when they are displaced, they don't always have the means for transportation, and therefore movement going to the PHC becomes a real hurdle. So we had to go to them. We piloted this with UNICEF with 20 mobile clinics, and by when the actual war came in September 2024, with the help of the partners, we were able to increase that mobile clinic number to 250 mobile clinics, and we were able to connect shelters with PHCs, and we were actually going to the patients rather than asking the patients to come to us. And we use the applications present, the LMS and the Phoenix, to be able to give them their, the chronic medications. So to finish my presentation, I want to share with you what I consider the cross-cutting lessons learned from the experience of the Ministry of Public Health during the displacement crisis of 2024. The first lesson is to anticipate crisis before it happens. The most critical resource is not money, it's not medications, it's not medical supplies, it is time. And therefore, the more you prepare before the crisis, the more time you will have to be able to plan and execute. The second lesson is that care must become patient following. We cannot wait for the patient to come to us. In displacement, you have to go towards the patient. The third lesson is continuity is the real outcome. If you cannot ensure continuity in the reach of the services to the patient, then your health outcomes will be badly affected. Fourth is digitization is not a luxury. Digitization is key, and it is essential if you want to implement properly, that you digitize your workflow and your system. The fifth lesson is partnerships are essential. If we had worked the crisis, each partner alone working in silos, it would have been very inefficient. We would have seen a lot of redundancies, and a lot of people would not have had access to care. And finally, sometimes the playbook of dealing with such crisis has to be written within the crisis, and therefore it's key to maintain a adaptability and a mentality of adaptation and iteration as the crisis unfolds. Thank you very much for the opportunity. Back to you, Dr.
Thank you, Your Excellency, Dr. Firas, for your comprehensive and interesting talk. Now we'll move to the next presentation. Dr. Nadine Hilal has served as advisor to the Minister of Public Health in Lebanon since 2021, leading national public health strategies and system strengthening initiatives in collaboration with international organizations. Since May 2025, she has also served as national consultant for the health reforms at the WHO country office in Lebanon, developing reform agendas and facilitating health system change. A practicing rheumatologist, she holds a master's degree in public health with a concentration in health management and policy, and has contributed academic publications in both rheumatology and public health. Please welcome on board. Welcome for your presentation, Dr. Nadil. The floor is yours.
Okay. Hello, everyone. Thank you, Dr. Mina, for organizing this, and thank you, ISPOR Lebanon chapter. It's both easy and hard to speak after Dr. Abiad, especially that with all the details that he have shared. The good thing is that the 2026 response is kind of an extension of the 2024. So I will be just sharing some key areas or providing an additional overview or maybe or a different perspective, but be prepared that many of the things that he has mentioned are already part of what I'm going to say. So the response I will start by sharing an overview of the health response that we are currently having at the Ministry of Health. So the response is being coordinated by the Public Health Emergency Operating Center, also known as FEOC. The FEOC was established in 2023 following the war on Gaza and the escalations in the south back then. Since that time, before that, we had a lot of efforts. We had also a system called EOC and several other namings for emergency response. But the formal FEOC, as you know it now, has been established in 2023. So the FEOC is the main coordinating center for all emergency preparedness and response activities, and it reports directly to the minister, and it coordinates with all health sector partners for that purpose. Now, for this emergency response, as in any other emergency response, there are several pillars. The first one, and probably the most you know about, is related to casualty care. So the FEOC, aside, and before we talk about casualty care, definitely we need to talk about preparedness for casualty care. And this is usually carried out over a period of months and maybe even years of enhancing the preparedness of hospitals through trainings, through drills, through simulation exercises, through supporting them with medications and supplies, through addressing their needs so that they are more prepared whenever an incident occurs. And this has been ongoing since 2023 in different areas related to, for example, preparedness on mass casualty management, on traumas, management on burns, and several other areas. Once an incident occurs, such as this one, the FEOC also coordinates or plays an important role in coordinating the activity of ambulances, of emergency medical services, giving its knowledge of the hospitals, where do we have beds, where do we have ICUs, the availability of different specialty areas. It also tries to direct these emergency medical services towards where there are vacancies or availabilities. Another area is the coordination of the work of the emergency medical teams. Most of these are typically specialized or highly specialized teams which are deployed as missions from outside the country. So the FEOC identifies the needs, the hospital that they need to be deployed to, and also coordinates their role. An important aspect is the production of data. All the dashboards and the data report that you see on a daily basis produced from the Ministry or issued by the Ministry of Health are the work of FEOC. Now, focusing on casualty care, Just also under the umbrella of financial protection, the Ministry of Public Health, as in all emergencies, has issued a decree or a decision to waive all patient contributions. So far it has been covering more than 8,000 cases of casualties at the expense of Ministry of Health in whatever hospital that a casualty reaches to as a result of war. Now, a very important area, which is equally important to casualty care, is the care of the displaced. And here we talk about several levels of care. The first one is the primary health care, and also we are concerned with secondary and tertiary care. So regarding primary health care, the primary health care centers, which is a network of around 340 centers, are the ones responsible for the care of displaced people, especially those who reside in shelters, but for all displaced as a population. So they are responsible for providing all the services, whether it's acute care, like any acute condition requiring primary care, or managing their chronic diseases, NCDs, vaccinations, all other mental health issues, all those that are might be needed for any individual, whether displaced or not. Additionally, as Dr. Abiad also mentioned, we know that sometimes people will have challenges accessing these centers, especially those who don't have a transportation mode. So in addition, we have been mobilizing more than 200 mobile units who have been visiting these shelters and taking care of the people there, addressing their needs, and making sure that there is no disruption in services. So worth mentioning here that despite all of this crisis, the primary healthcare centers were also able to continue essential services and minimize interruptions. For example, we have been able to vaccinate 8,500 child, and this will also help in making sure that these children don't miss important developmental or important milestones in their vaccination calendar. Now, aside from primary health care, we also know that many patients require secondary or tertiary care services, including dialysis or chemotherapy, and I will not talk about this anymore, but also sometimes acute services. For example, many ladies would need to deliver, many people might develop strokes or acute MIs. So all of these there has been also a dedicated team at the Ministry of Health to take care of these patients and direct them to a specific set of hospitals which has been identified by the ministry, geographically distributed throughout the country to address the needs of the displaced population. Also, financial waivers were made so that the financing does not contribute a burden or a barrier to access to care. And here we have been also partnering with many health sector partners, UN agencies and NGOs who have also supported this secondary care and tertiary care by covering some of the patient share in different specialties and different areas. All of this also have been facilitated through a very active call center. We have 3 dedicated lines for different areas. One of them is only for mental health, dedicated for mental health. Another important aspect of the response is the surveillance. So we also know that during displacement, infectious disease tend to flourish. That's why the surveillance team at the ministry has been very active, whether through active surveillance or the call base that we receive. And we have been identifying a lot of potentially threatening conditions. For example, we were able to identify one case of meningitis in a school, and luckily it was isolated and treated before another disaster would have taken place. Other surveillance findings were mostly related to skin diseases and food poisoning, and most of them were being addressed at the primary healthcare centers. A fourth component of the response is the management of donations, and as you all are aware, at times of crisis, no matter how prepared we are, we always need an extra hand, especially when it comes to medications and medical supplies. So the ministry always issues updated list of what do we need in terms of medications and supplies, and we share it with all our supportees, including embassies, including UN agencies, including our diaspora community, and whatever we get, it all automatically gets into the system up to the smallest unit into our logistic management system, and it could be tracked by our digital tracking systems. Other aspects of the response, like partnership, I will leave it to my friend Dr. Shajib. Dr. Abiad has already talked about digitization and communication. So I will be focusing on key areas just from an analytical perspective. So regarding the most recent numbers that we issued today from the Ministry of Health, we have 2,696 martyrs and 8,264 casualties. So the ratio of martyrs to casualties is 1 to 3, and this ratio is considered significantly high. And in the studies of war and conflict conflict medicine in general, this means typically two things. The first one is that the injuries are severe, and which we already know it because of the types of weapons, military weapons that have been used. The other important conclusion is that the health system is responsive, but it is under so much strain. And when we talk about health system responsiveness in such case, we mean all the way from the moment that the casualties are being evacuated up till they reach to the intensive care or wherever they are being served. So it tests all of these levels. It's not only about what they receive at the hospital, but it's from the moment they are being even the first responding moments. So being under strain, it like put a lot of questions regarding sustainability, how much the health system would be able to sustain if this conflict or this crisis is is more protracted. So this is something we all need to, of course, consider. Another important consideration is that we have noticed that the attacks are happening at the level of communities, and this we have noticed in two areas. The first one is the percentage of women and children that have been martyred or counted as casualties, which is 20%, which is a very high also percentage, which we have been seeing in wars like war on Gaza or the Syrian internal conflict, and this means that the communities are being directly attacked. Another evidence is the huge losses we have to the health sector in terms of people and also in terms of equipment and centers. So we have 103 martyrs from the health sector so far. We have 119 emergency medical services vehicle which has been destroyed. We have 16 hospitals attacked, 3 of them totally out of function. We have 40 primary healthcare center also non-functional at the moment. And all of these also make us ask important questions or have important discussions need to be made about rehabilitation, both human rehabilitation because of all of this community-based attacks and community-based damage that have been ongoing, but also health system rehabilitation. And when we talk about human rehabilitation, I think two of the most important are the mental health, which needs to receive special attention during the war and even beyond. And the second one is the physical rehabilitation, which is very often under it does not receive the attention it deserves when you talk about health system responsiveness. The third area I would like also to briefly talk about is the vicious cycle of displacement and return. And I'm saying here vicious cycle because definitely we would love for everyone to return and to start building back their homes and communities. But with the current ongoing protracted crisis, this is a vicious cycle, and puts additional strain on the health system, because on one hand, the health sector partners, including the ministry and all NGOs and all UN agencies, are asked to scale up their response to support the IDPs, but on the other hand, they need also to support the returnees in whenever they are. So for a system which is already stretched thin, stretching it further definitely will create breaks unless we do something about it. So what needs to be done? Maybe I will be leaving you with more questions or more things that will open discussion than because I think what needs to be done in the aftermath of this crisis maybe warrants a session on itself. I think we all need to review the way we need to work more about regarding our emergency preparedness. Also, we need to find ways in which we can spare health of whatever national or regional or global challenges that might take place, whether economic or political. The government needs to prioritize health and spare it from any crisis that, or any political or financial crisis that it could be faced with. Even at the level of the ministry, I think despite that we have come a long way from 2024, all the preparedness back then, the lessons learned, and then up till 2026, I think there is also much need that can be done in the way we manage our finances, in the way we look at our budget, in the way that we enhance our preparedness, maybe have a health emergency master plan, identify key centers where we need to build, for example, to establish burn centers, polytrauma centers. There is a lot of things that we can do to enhance the health system resilience. This might be a topic or an area of further discussion. I think I have left you with more questions than answers, but I think this is how things are whenever we want to dig into a very complex and a sophisticated matter like preparing for emergencies. Thank you again, and thank you for your attention.
Thank you, Dr. Nadine, for your presentation. Now we will move to the next session. Dr. Shajib Hussain. Dr. Shajib Hussain is a medical doctor and a humanitarian health specialist with over 15 years of experience in emergency preparedness, response, and resilience across East Africa, the Middle East, and South Asia. He holds a Master of Public Health from Mahidol University and has completed advanced training in health economics at Harvard University and the London School of Economics. Since August 2023, he has served as health sector coordinator with WHO Lebanon, and previously spent 4.5 years as planning officer with WHO Somalia. Earlier in his career, he led complex emergency responses with Medicines Sans Frontières, Cap Anamur, and Action Counter in La Fame. A two-time recipient of the WHO Director General's Award for Excellence, he is also an active researcher with publications in leading international public health journal. Please welcome Dr. Shajib Hussain for your presentation. Thank you.
Thank you very much, Maher, and good afternoon, Excellencies, colleagues, and partners. I do have a few slides. Let me try to share it from here. And while I also speak, open the system. The technology is always like being dubious. and whenever it is needed, it doesn't help us. Please allow me 1 minute. There you go. Okay, well, I tried. It's not working for one reason or the other. So I will just go through it as it is. So I would share my experience here in Lebanon. As Maher has mentioned, I have been here since 2023, and before that, I have been in several other complex emergencies, including a few in Middle East. And what really is most important for me is the discussion and dialogue we are currently having right now around the synergy between humanitarian action and the health system. Because for me, it's no longer a conceptual discussion, it's rather a operational necessity. In any protracted crisis and complex crisis like in Lebanon, the line between the humanitarian response and the humanitarian narratives and the national health system is increasingly blurred. Humanitarian actors here in Lebanon are no longer working around the health system. Rather, they are working within it. For example, my previous speakers, His Excellency Dr. Abiad and also Dr. Nadine Hilal has very specifically mentioned the role of the primary health care, the hospitals, the disease surveillance, the health workforce, the supply chain. All of them are largely the national structures within the health system. They are already
Sorry, Dr.
overstretched.
Shajib, we cannot see you. Can you open your camera, please?
Oh, apologies. So I think, I don't know which one did I press. Yeah, can you see me now?
Yes.
Oh, excellent. So all these are already overstretched. And when we have on top of this acute onset emergency, absolutely, it is going to test the system tremendously. And if humanitarian actions, when we step in responding to this kind of shocks, if it is not aligned, we always risk fragmentation. And Dr. Abiad has already mentioned about it. We always risk duplication and introducing parallel services. And sometimes we unintentionally weaken the very health system that we work within. So synergy, therefore, is not about integration in theory, it's for our own survival and the continuity of the healthcare. So many of you are aware that what the health sector coordinator or the health sector coordination does. And it's a quite interesting topic because every individual that I have asked so far, everybody gave me a completely different answer and their expectation is very, very different. Like traditionally what we do, we arrange meetings. We are very famous for arranging meetings. Like every day, like whole day we meet with people. We create maps, data products, and we also generate reports for donors, partners, and also for the national health authorities. But in current operating environment, coordination is also a leadership responsibility, and it is happening more and more often. So as a health sector coordinator for me here in Lebanon, and also to my colleagues in different other complex emergencies, this role increasingly involved the stewardship function to the supporting of the health sector partners and also facilitating the collective decision-making under the uncertainties. And why I mention uncertainties, because most of the time during these complex emergencies, we really don't know where it is gonna end. And this is where I think our experience and expertise comes in handy with the capable hands of the national authorities and the ministries of public health. In Lebanon, what we do, as Dr. Abiad and Dr. Hilal has already mentioned, the role of the Public Health Emergency Operations Center, or FEOC, what they're playing, and they are doing fantastically. So as National Health Sector Working Group, we work as an interface between our health sector partners, which is a group of people and different national and international organizations, civil society organizations, with the disaster risk management structures, our operational partners, and donors. And we bring everybody under one umbrella, which is the umbrella of the Ministry of Public Health. And we serve as the interface between all these partners and the FEOC. But most frequently, what we also see is the leadership here is often invisible. It's not about directing, it's about aligning, it's about negotiating, and also building trust under pressure. Because most of the time what happens, that people really don't see the need of the coordination until and unless they notice that something is not going right. And as mentioned during the presentation from my previous speakers, there has been a lot of discussion about preparedness, and this is what we also do as a health sector coordination team. In November 2025, we have conducted a rapid health assessment together with the Ministry of Public Health. And that data itself helped us crafting the Lebanon response plan, which is one of the integrated humanitarian response framework for Lebanon. In parallel, when we were updating the Lebanon response plan, we were updating the national contingency plan for the health sector. That was reflecting the real operational risk. And it was happening back in December 2025. We were updating our contingency stock, and we were also consolidating across the partner that who can contribute in these contingency stocks. And His Excellency Dr. Abiad already mentioned the utility of this during the last response also. But what mattered the most for us here is not only about the output, but the process. It became a shared exercise, bringing all the humanitarian actors together under one platform, which is the Ministry of Public Health. And we did this joint risk assessment, capacity, and gap assessment. And this is where the humanitarian response stopped being episodic and start reinforcing the system readiness. And during the current episode of the hostilities and the displacement, synergy is being tested on almost on a daily basis. Dr. Nadine has very generously shared the numbers that what has been done. At the same time, I would also highlight three specific things that we do also in Lebanon. First of all, we focus a lot on the dynamic mapping of the partner coverage. In many other countries, we focus on the 3 Ws, the famous 3 W, the who does what. So we took it to the next step, which is a dynamic process so that we can have the real-time update. We introduced the rapid problem-solving spaces. Our partners can reach out to us through FEOC, to Ministry of Public Health, whenever they face any challenges, whenever they face any issues with referrals of the patient. At the same time, whenever they faces any logistical issue, and one way or the other, we are able to resolve them. And finally is the information as a coordination tool. And this is how we influence the outcomes. Information management done by the health sector coordination team is one of our core functions that we deliver for the global health cluster globally. And currently we have approximately 21 activated clusters and more like operational clusters or sectors globally. So we produce the emergency situation reports, the service availability dashboards, the guidance documents, the success stories. And many of our colleagues might say that, oh, these are different kind of reporting tools, but it always enables us to respond faster. It helps us to take evidence-based decision, both among the humanitarian partners and the national authorities. For example, the National Health Sector Portal, which is one of the information hub for Lebanon, has more than 23,000 visitors since the onset of the crisis, the latest crisis. So that also showcases that it has become a shared reference point across the partners. And you can always ask me that why we are focusing so much on the information product, on the data and everything. For me, the shared data creates shared accountability. And it also reduces the power asymmetries. And it's a transparent prioritization that allows both humanitarian actors and the government counterparts to operate from the same evidence base. And this is very, very critical for the leadership infrastructure. And finally, all the synergy components that I have been speaking about, it won't happen without the correct, or let's say not correct, right financing logic. In fragile settings like Lebanon, funding often arrives earmarked, short-term, emergency-driven. While this is understandable, it can be unintentionally reinforce the fragmentation or weaken the system itself. So our role is to make sure that we engage our donors not only as a funder, rather as a strategic partner, so that they also participate in the decision-making, in the strategy development. And we encourage alignments with sector priorities, contingency plans, and the national strategies so that the individual grants contribute to shared outcomes. When donors, humanitarian actors, and national authorities operate from the same evidence base, shared priorities and resource mobilization becomes a force multiplier, not just a funding exercise for us. So we all must acknowledge that the leadership here is not positional. And this is something that Dr. Abiad has also mentioned, and I'm just quoting him again. It's not about positional, it's relational, it's adaptive. And it is being exercised on a daily basis, often quietly through the coordination choices. So let me close with one reflection. So this is the final reflection from here. So coordination should never become just another layer in the response architecture. And we can easily test it very easily. If humanitarian action consistently leaves the health system stronger and more connected and more trusted than before the crisis, then we are on the right path. And this is the leadership challenge that we face on a daily basis. And that is also an opportunity if we can take the lessons learned and move forward. So thank you very much all.
Thank you, Dr. Shajib, for your presentation. Now we will move to the next session. Dr. Brahim Bououroum is a senior lecturer in global health at the Liverpool School of Tropical Medicine in the UK and at St. Joseph University of Beirut. His research focuses on strengthening health systems in settings affected by fragility, conflict, and forced displacement. He has contributed to major global initiatives, including the Lancet Commission on Health, Conflict and Forced Displacement, and the FCDO-funded Rebuild for the Resilience Program. He has advised WHO and other UN agencies on health system resilience and recovery, and serves on the advisory board of the Health Systems Global Thematic Working Group and on fragile and conflict-affected settings. Please welcome with me Dr. Brahim Bououroum.
Thank you so much for the opportunity to contribute to this very interesting discussion. And Today I'll be speaking in about 10 minutes about conflicts, forced migration, and health systems. And I'll try to move us really from thinking about frameworks and structures to the realities experienced by people on the ground. So it's really trying to let us reflect on how systems respond or unfortunately fail to respond to people living through instability, displacement, and protracted crises. I would like to start with really situating a discussion within the broader global context that we're living in. So, after a period of globalization, as described by some economists, specifically after the 2008 economic crisis, we are currently witnessing a period of what some also political scientists and economists call it deglobalization, really, because of weakening multilateral cooperation and also the shift towards national self-interest, which is kind of which actually has direct implication for global health, particularly in terms of financing, coordination, and shared responsibility. At the same time, protracted crises are no longer the exception, so they are the norm. Conflicts around the globe and in our region are lasting longer, and displacement is becoming increasingly long term rather than temporary. And on top of this, we have climate change, and our region is one of the really most affected by climate change. It is not only increasing disease burden, but also acting as a driver of displacement and fragility. If it's not now, definitely in the future. So the result is that health systems in our region are under pressure from multiple overlapping shocks. So whether it's conflict, epidemics, climate change, and also they have to deal with a growing burden of non-communicable diseases and mental health conditions. If we look at global displacement trends, the scale is also unprecedented. So millions of people are forcibly displaced every year, and sometimes at a kind of a multiple iteration, meaning they are displaced several times, both internally and across borders. Sometimes across border displacement, which is kind of the refugee situation, is getting more attention, but the reality is the majority of forced displacement globally is internally displaced is about internal displacement, and these displacements are protracted, lasting years and decades. So if we look just at the numbers, whether from the UNHCR estimates, we're talking about 73 million internally displaced people, but also from another source, the IDMC 2005 figures, we're talking about 83 million. And the problem here is that this number doubled over the last decade. So we moved from having 40 million to 80 million in just one decade. And in our region, it's the same situation. So the majority of forced displacement occurs, and the majority of forced displacement events occur within borders. So in a sense, within the states. And we're talking about at least 16.6 million internally displaced people by the end of year 2024. And unfortunately, the cost, sometimes we try to estimate it, but usually these are underestimates. So because they look sometimes at just short-term cost, including the figure on the slide, and they fail to account for long-term consequences such as disrupted education, reduced economic productivity, and intergenerational impact. If I want to spend just a minute really to look at the conflict-related mortality, the number also are struggling, but also incomplete. So in Syria, Yemen, Sudan, Gaza, and Lebanon, we see both direct deaths from violence, but also a much larger number of indirect deaths, which sometimes are not on the slide, but also sometimes not estimated. And that's why I asked the question, really, who's counting and what's being counted? Because as you probably know, what we measure really shapes what we prioritize and what we can advocate for kind of assistance and health system reforms. In addition to mortality, the burden of preventable morbidity in settings affected by conflict and forced displacement is immense. I'm not talking just about maternal and child health indicators that have deteriorated sharply in several conflict settings in the regions. I have figures on the slide from Yemen, Sudan, Syria, and unfortunately in Gaza, we know all the kind of the situation where premature babies died due just to some kind of infrastructure issues and fuel and equipment shortages. But at the same time, we are also seeing in many countries outbreaks of communicable diseases and also a kind of a re-emergence of communicable diseases that we controlled for a long period of time, including, for instance, cholera in Syria during the wars, the kind of the years of the war. And at the same time, non-communicable disease and mental health conditions are becoming dominant. Again, figures from Palestine are really striking. So even before the 2023 war, 50% of children in Gaza were found to have some kind of a PTSD risk or have PTSD symptoms. And this is just one slide showing one neglected war in our region, which is the Sudan war. And just after 3 years, really, you can see the scale of mortality. You were talking about over 150,000 deaths estimated. And also, we're talking from a forced displacement perspective, we're talking about at least 12 million displaced people, specifically in the western part of the country. So what's the issue really? And this actually brings us to what I call it the mismatch. So the gaps and the really between the realities and actually how we are trying to address the health needs of communities affected by conflict and forced migration. So traditional humanitarian health models were designed for short-term emergencies, often in camps, and I've visited some camps, including this one in eastern Mauritania that hosted about 120,000 refugees from Mali. And there are some opportunities, some positive kind of experiences around the globe. But unfortunately, these camp settings are not the norm globally. And really, kind of this approach of parallel service delivery system is not really kind of the best option for most displaced population around the globe because today's displaced people live mainly outside camps, often in urban or informal settings, and as I said before, remain displaced for many years and rely heavily on national health system, not really parallel a humanitarian structure. And this creates a fundamental disconnect. So humanitarian models remain temporary and working in silos, but the reality is different. The reality is long term, and the reality is that kind of really a burden that usually host communities are absorbing silently sometimes, and financing, planning, and data systems sometimes also struggling to adapt this new reality of mobility and forced displacement. There has been some recognition of this mismatch again since 2016 with the World Humanitarian Summit and the New York Declaration. There has been increasing acknowledgement that displacement is not only a humanitarian issue but also a development issue. There has been a push towards integrating refugees specifically into national health systems and moving away from purely emergency based response. But and again, some colleagues at Johns Hopkins University, so Shada and Naqib and colleagues, looked at this from an international policy perspective, and they witnessed that this surge in really the global attention followed the Syrian refugee influx into Europe and the growing securitization of the crisis. So that's why we can tell that the greater emphasis was really on refugee integration, with comparatively limited attention to the development needs of IDPs and conflict affected host communities. So, what are these structural challenges, if I may say, particularly in highly fragile and fragmented systems, in those settings that are most affected by conflict and forced displacement? So, in most settings, including some features that are applicable to our country, we see highly privatized and fragmented health systems. We see also sometimes really workforce depletion and migration of workforce to better places and challenging governance capacities. At the same time, healthcare is increasingly under attacks and politicized in conflict settings. So you can tell now the norm is that, as I called them before, in contemporary wars that, attacking civil infrastructure, attacking healthcare systems is becoming the norm, unfortunately. And this means that health systems are not only under strain, sorry, because of high needs, but also they are operating in contested and insecure environment. So the issue is not just weak systems, but systems that are actively disrupted and instrumentalized. So when we move to recovery, of when we need to discuss resilience, and I know I have a couple of minutes to do so, which is a challenge by itself, but the challenges are a bit also similar but slightly different. So this, as you all know, there is currently a chronic underfunding from the global funding and the global humanitarian development donors because of the different challenges, changes in policies at the global level, but also economic crisis globally affecting donor countries and donor governments. And this is affecting, as I said, long-term recovery and system strengthening. Because if we want to discuss resilience and recovery, resilience is not just about absorbing the shock. It's really about trying to transform the system to a better place, right? But unfortunately, those long-term health system strengthening opportunities or transformation is consistently deprioritized. So even when infrastructure is rebuilt, we need with that investment in governance capacities of countries, but also in workforce, primarily primary care workforce, and also supporting countries to have sustainable domestic financing. Otherwise, they will be kind of in the same status of being dependent, being fragile, and being dependent on external factors. And as you all know, recovery, health system resilience is not just a technical process, it's not just about giving recommendations from experts, but it's deeply shaped by political economy dynamics and really by how much you have governance, strong governance in place, how much legitimacy in some settings, and the power relations that play a central role in really kind of pushing this system to a better place. If I want to jump in for the sake of time into some concluding reflections, and if I'm rushing things, I'm happy to take questions later on in the panel. But just for some of the concluding reflections, one is forced displacement in the EMR and globally is not temporary. So the dynamics are changing, and while really humanitarian responses are essential, they remain reactive, short term, and structurally disconnected from the realities on the ground. Health systems resilience and recovery must adapt, must really we have this need to move beyond incremental improvement or vertical thinking towards rethinking our paradigms, rethinking, the roles of different actors. And health system resilience is in this context is not just, as I said before, it's not just about absorbing shocks. It's about transforming the system, the health system, towards better continuity of care, but also more equity and not just emergency preparedness. And we don't want to forget that finally achieving universal health coverage in these settings is key, and it requires systems that can function during instability, not only in stable contexts. We don't want to wait until we have full stability because unfortunately it's not being the case, and we need to push the UHC agenda as soon as possible and keep on doing so. This means, again, aligning a humanitarian and development approaches and adapting policies and financing mechanisms accordingly. So to summarize, and thank you so much for the opportunity again, we're no longer dealing with temporary crisis, we're dealing with long-term, complex, and overlapping challenges, and this requires us to move from crisis response to reimagining health systems. Thank you so much.
Thank you, Dr. Baarum. Good afternoon, everyone. The panel discussion will be facilitated by Dr. Basima Hazima, Treasurer of the ISPOR Lebanon chapter, and myself, Rita Sneem, President-elect of the chapter. I'd like to thank our speakers for these insightful and thought-provoking speeches. What we've heard today clearly shows that coordination is not just a technical exercise. It is central to whether health outcomes are protected or compromised in times of crisis. Let's now open the discussion. I'll start with Dr. Nadine Hilal. Dr. Hilal, would you please open the camera?
Yes.
Hello again.
Hello.
Lebanon has unfortunately been through repeated crises. Do you feel the system was better prepared this time compared to the previous war? Which shortcomings were effectively addressed, and which ones still persist despite prior experience?
ثانك يو ريتا. هلا انا بعتقد انه نحن في شغلتين عم تشتغل باتجاهات معاكسه. من ميلي نحن صرنا مور اكسبيرينسد، البلانز اللي حطيناهم بال 2024 عم نرجع بنطبقهم وبنحسنهم. كمان it happens انه نحن تقريبا same team that was يعني اللي على الارض that اكيد الليدرشيب تغيرت، بس كمان يعني both excellencies have more or less the same mindset in addressing emergencies. كمان هيدا الشيء بخليكي انه you are consistent with the plan. Same people who have been working على الأرض يعني leading on different areas are still the same. كمان هيدي الشيء انه بعد ما لحقنا ننسى للأسف، بعدنا بلشت الحرب دغري we hit the ground running يعني مثل ما بيقولوا. So من هيدي الناحية we are more comfortable with the plans, we are more confident in what we do. We have tested these plans earlier. بنعرف شو اللي اشتغل وشو اللي ما اشتغل وشو اللي لازم نحسنه. We have done like immediately within 2 weeks من ال 2024 emergency عملنا exercise اللي هو evaluation of the response, lessons learned. It was led by the ministry but it was attended by all people who were involved in the response. وطلعنا منه كمان دروس، الأشياء اللي هي نجحنا فيها، الأشياء الجابس اللي كانت عنا، الأشياء اللي كان لازم نشتغل عليها. واشتغلنا على قسم كتير منهم. للأسف في كتير أشياء ما قدرنا نشتغل عليها، وهيدي الديفيشنسي والجاب اللي هلأ نحن عنا إياها mostly related to financing. بس كمان في أشياء هي structural. for example أعطيكي مثل إنه نحن قسم كبير من الناس من الفيوك اللي هلأ كل الوقت عم نحكي عنه 100% of the staff of the FEOC are not Ministry of Health staff. They are outsourced by UN agency, basically WHO. وهيدي كمان it's a challenge for the continuity of such program. And it largely depends on availability of funding. يعني كمان أبعد من هيك السنتر اللي هو الفيوك it's not even part of the organigram of the ministry. لترجعي تقدري تحطيه بالorganigram it needs a lot of. هلا منيح دكتور بلال معنا بيحكي أكتر يمكن هو عن هيدا الموضوع. أكيد نحن هالمرة السبورت الانترناشونال سبورت is much less. We have witnessed it بالhealth كمان we have witnessed it بالresponse as a whole. So basically اللي فينا نقوله إنه نحن بكتير محلات بنعرف شو لازم نعمل but sometimes ما عنا enough resources to do it. We are more mature in terms of our response. What could help إنه do more simulations, do more preparedness plans for different scenarios. أكيد this would help even more. بس قد ما تعملي يعني أنا فيني أعطيكي هلا يعني an example which happened in the 2024 response despite all the simulations. لما صار انفجار المرفأ انفجار البيجر بسبتمبر 17 at that time كان في thousands of injuries، وبتعرفي قسم كبير منهم كانوا بالفيس و they needed eye intervention ophthalmologist. So بوقتها يعني تواصلت مع دكتور أبيض وحكينا حكيت مع رئيس جمعية حكماء العيون، جربت أتواصل معه خطه مسكر، بعت له مسج بليز كول مي urgently إنه we need نرفع الجهوزية بين حكماء العيون. بعد شي نص ساعة بدق لي بيقول لي نادين نحن هلا واصلين على مطار برشلونة، نحن 10 to 15 ophthalmologists من academic centers كلنا هلا واصلين we have a conference ببرشلونة. قلت له دكتور بليز رجعوا هلا، يعني إذا فيكم ترجعوا هلا ارجعوا هلا. وبالفعل قسم منهم رجع بنفس الليلة، قسم منهم يعني it took them 1 or 2 days to come back. بس هون أهم يعني sometimes as much no matter how prepared you are some things you need to adjust on the spot. some things يعني بدك تعملي أشياء يعني you are always on the move. You always need to be flexible and agile. People need to be responsive with you. حتى إذا نحن as a ministry were يعني we had plans but إذا people did not support, people were not responsive, it will not work. يعني it needs this collaborative partnership, collaborative governance to make it happen.
Yeah, thank you, Dr. Nadine. Dr. Abiad, bringing in your perspective as a former Minister of Health, how can national leadership retain control and strategic direction in such complex settings? where multiple actors are involved and where when much of the funding is externally driven or provided?
Thank you. And I think that you already answered the question within what you said. First of all, it is very important if we want to take leadership, we need to put some of the resources on the table. And this is extremely important. We cannot continue to live on the charity of others. Okay, يعني مثل ما نقول المصاري بتحكي. And I believe we need within our budget to allocate some budget for activities, centers such as FAYO, having the right organization within the ministry that will allow us to be in control. مش ناطرين لحتى حدا نجي يتصدق علينا ويمولنا هالبوزيشنز، وخاصة إنه تمويل the funding of the international community لأنه humanitarian it's yearly so any change in their budget مثلا لأنه let's say the US does not contribute أو بدها تسكر USA فجأة بتلاقي an essential function in your setup تسكرت لأنه بقى في fund. So I think that this is the number one issue that we really, if we want to be in control, we have to find the means to be. The second is an attitude issue, in the sense that sometimes some of our organizations or public institutions, or including the ministry, find that by not being in control, it means that they have protection from responsibility. لأنه when you are in control, it means you're on the hot seat. When you are the one being seen by the public as controlling any event, it means that if something goes wrong, you are the one to be blamed. And therefore, for some of our, they find it easier to step aside, and leave others in their mind, then they will not be held responsible. My experience is they will be held responsible whether they are in control or not. لأنه sometimes even the international organizations, even if they are in control, they will point the finger at you. And they will say, you are the public institution, you should be blamed, even when you didn't make the decision. And that is why, in the Ministry of Public Health, whether during COVID or during cholera or during the war, we thought that we need to be in control. At least, if something goes wrong, we would have tried our best, better than to sit aside and allow the others to be. So I think that these are the two main things. First is the will to take responsibility. Second is to, put resources on the table. Doesn't mean we have to bankroll everything. At the end of the day, the internationals are doing it for many reasons, not only as a favor. They are doing it because it's a shared responsibility. We host a large number of non-Lebanese refugees because global health is global health. So anything that goes wrong here, if we don't control cholera, it will move to other places. ما عندنا نقول سواد عيوننا. بس we cannot say we have to كل شيء نحطه على ظهرهم. ما بتمشي.
Thank you, Dr. Abiad. It was very insightful. I'd like to pause here to see if any of the panelists would like to add or build on what Dr. Abiad has just mentioned about this. Okay, wonderful. So, Dr. Hazima, I'll hand over to you to take us forward.
Good afternoon, everyone. You can hear me?
Yes, Basima, please go
Okay,
ahead.
perfect. Again, I echoes my ISPOR board member to thank our esteemed speaker and panelists. also, I would like to thank all attendees for their time, and hopefully we can meet physical and future event under different circumstances. Basically, my question is to Dr. Bouaram. Dr. Bouaram, based on your experience and at the time of crisis and when resources are extremely limited, prioritizing immediate humanitarian response can come at the expense of long-term system resilience. From your policy, as a policy perspective, what are the different approaches that have proven effective in aligning the direct emergency response with the long-term health system resilience? Thank you.
Thank you, Basma. Thank you, Dr. Hazimi, for the question. Apologies, Maratani, for the presentation itself. I would start by challenging the assumption a bit, because, as I mentioned in the presentation, we're not really dealing anymore with short-term shocks and short-term emergency. Crises are protracted, displacement is urban, displacement is informal. So really, I think that there is no real trade-off anymore. So really, we're talking about contexts where short-term humanitarian action and emergency response, and as I said, I'm not undermining its importance. دكتور أبيض ذكر بالمداخلة تبعه أهمية مثلا dialysis, تحضير continuity of care for cancer care, is that if we have patients living with type 1 diabetes. But really, I think both of them, meaning the short-term emergency response and the long-term system strengthening today, need to be designed together and not sequenced. لأنه in many settings, أي متى بتنتهي الأزمة, we don't know. And there is a risk of backsliding into violence, into crisis at any time. And our country is unfortunately one of the best examples. If I want to go into trying to answer your question, which is a difficult one, I had kind of few points to highlight. One is, of course, you can still protect life, but in ways that builds health systems. مثل ما جربت أقول بالأول. So emergency service kind of delivery should be embedded within, or at least aligned, if I may say, to national health systems whenever possible, rather than creating parallel structures. The lesson from Lebanon, and I'm here with the leaders who did it, so in a sense is that the primary care, the investment in the primary care network was partly due to really the Syrian refugee crisis. So this is an example where instead of creating a parallel structure, we had leaders who thought about really a development opportunity as well, and strengthening this buffer, if I may call it, apologies for the term, kind of, and I don't want it, unfortunately, still at an alternative for some vulnerable communities. The second point, and I think Dr. Hilal mentioned it in a sense that, the ministry was strong to really say, like, these are my priorities, and if anyone would like to support me, I'm here to get this support. So the message really from a technical perspective is that this prioritization or this support should be function-based, if I can call it, using the health system language, not really based on one service or on one program. And we have a lot of examples. I mentioned the example of primary care, but we have a lot of other things. But then if we work with local leaders, then they would tell you the high impact entry points. دايما كنت أعطي example غزة. غزة وقت كان في الحرب، أول ما وهيدي in line with what Dr. Abiad mentioned, أول ما أعطاهم the resources, they managed to run a successful vaccination campaign for polio. So this is, again, sometimes, the know-how with local authorities is there. And of course, the last point that I would like to mention is that we need, of course, to be realistic about fiscal space. We're all here on the panel focusing on the importance of domestic resources, but without neglecting the importance of external support. But again, going back to Dr. Abiad's point and the challenges between, and we did some work in Northwest Syria. And the funny story is WHO, is it coordinating, leading, when we start partner state? I'm not leading, I'm coordinating. And I think Dr. Shaji would agree with me. So definitely the point here is that really we need all parts together. So again, the goal is not really balance between both humanitarian and long-term system strengthening. It's really integrating the strengthening approach, the development lens within the response. And apologies if it took a bit of time to explain it. Thanks. Over to you.
Thank you, Dr. Bouaram. This will help me to move from the policy perspective to practically on the ground, and to address my question to Dr. Hussein. Dr. Hussein, in a complex emergency, humanitarian coordination can sometimes lead to parallel system, as it has mentioned several times during our webinar. I can mention here fragmentation of services, creating different level of standard of care, reducing or diluting even the national local ownership and leadership. Based, Dr. Hussein, on your experience across similar contexts, what are the governance mechanisms or accountability framework that are critical to ensure humanitarian coordination reinforce the national health system capacity instead of duplicating or diluting it? Thank you.
Yeah, thank you very much, Dr. Hazima. I hope you can hear me well.
Yes, we can.
So also during my presentation, I have also mentioned that as humanitarian actors or the humanitarian framework, we do always add value if we are to avoid the duplication. And we can only do that when we are reducing the fragmentation you have rightly mentioned, and we are aligning our partners within the national health system priorities. And this is also something has just been mentioned by Dr. Boaram, because if we are able to bring everybody under the platform and the leadership of the ministry, of the national authorities, I think that's the only way we can avoid it. But most often what happens that in the essence of the humanitarian response, the adrenaline is pumping the response right, whereas we totally forget that there is a national health strategy. There are national priorities, and it cannot be left alone. Like I give you an example for Lebanon, we have a fantastic national health strategy 2030. We know the vision where we want to head. So whatever emergency response plans and frameworks we are crafting and developing, it has to be founded and integrated within the National Vision 2030. If it is not, we will be introducing the fragmentation and we are responsible. And here I would also like to say that you can easily test it. Like, how is it going? As humanitarian actors, how are we doing? I think it is a fundamental question that we should ask more and more in different contexts. Like, if the coordination is making the national health system more visible, if the coordination is making the national leadership more visible and trusted within the beneficiaries that we serve, then we are adding value. If it is taking the governance away from our partners and beneficiaries, then definitely there is a problem where we have to sit together and fix it. So I will stop here. Thank you.
Thank you. Very insightful. And now I will give the floor to my colleague Rita.
Thank you, Basima. I'll move to Dr. Bilal Abdallah. مساء الخير دكتور عبد الله وأهلا وسهلا فيك. We really thank you for being with us today. We know that you had a very busy day at the Parliament, so you made really free time for us to join this important webinar. Before starting to ask you the question, I'd like to briefly introduce you. Dr. Abdallah, you are a member of the Lebanese Parliament since 2018. You are a medical doctor since 1987, and you are leading the medical committee at the Parliament. So you are رئيس لجنة الصحة النيابية اللبنانية. Dr. Abdallah, my question to you is, from where you sit as a member of the Parliament, what worries you most about the system's capacity to absorb the shock, the repetitive shocks, and what underlying weaknesses are now being surfaced? Doctor, you are on mute. I think, please, could you...
Now it's good?
Yes.
Yeah, okay. I would like to thank Ms. Wadia Mina to invite me to this ISPOR activity. It's my pleasure to be with you all, with panelists, with speakers. Big pleasure to be with one of the best, our ministers, Dr. Abiad. I have been worked with a lot of ministers. Okay, I think he was trying a lot to do for our health system. I think we will continue with Dr. Nadine, with Dr. Rakan Nasruddin now. I think we'll try to make a bit headlines about our problems now, because you are doing discussion about the war and the displaced and the health system in this situation. Let me tell you first that unfortunately, till now in Lebanon, we don't have law. We don't have law who is managing the disaster situation. So why? So you see that the houses sometimes between ministers, between all establishments in Lebanon, nobody knows who is responsible for what. So why you can't take the health problems alone? It's related with all others, okay? We are trying to do that. We are trying to do this law, but it's sure it will not be soon. It's why we have a big problems, okay? Especially we'll have more problems in case the war will continue. It's seen that the war will continue now. Israel will not stop now, I think so. But I will give you some headlines that we have to mention as a followers of these problems on the ground, okay? In my region, I have 100,000, 30,000 displaced. On the times that as a local we are 120, okay? So you can imagine which problem we have in our region. First of all, that sure, we have big gap between needs and budgets. Minister of Health and all ministries are trying to do the best, okay? But sure, it's not enough. Nobody knows that Minister of Health doesn't cover all cases, okay? But displaced is coming to hospital and he wants to be covered, that's all. But unfortunately, a lot of costs are not covered. First problem. Second problem, some discrimination. Can you imagine the displaced who has the social security, not the Ministry of Health, is covered, okay? But it is not covered 100%. I am giving you an example that unfortunately we don't have unified instruction. This is because also we don't have, and I think Dr. Abiad with Dr. Nadine has been working on it, to have some protocols for this disaster situation. Each hospital, every hospital is working alone. His plan, his emergency plan, okay, his needs, his strategy. I have met that we have a lot of problem at ER, emergency places, at hospitals. Unfortunately, I think, and we should work for this, we don't have enough qualified people at emergency to manage when we have a lot of people in this situation. Sure, also we have big shortage in primary health care. Not enough, 340 in Lebanon, and now they are working. I don't know how they are managing this problem, but they are trying their best. Sure, but it's not enough. Also, we have big problem with banks of blood. We have shortage in many places with blood, and we have also big problem how to make one policy to services. Okay, we have Red Cross, we have apart with Red Cross a lot of others, okay, organizations, but they are not, I think, in one strategy or policy. They are not working, okay? So unfortunately, in this case also we have problem. So at the end, I want to say that we have best hospitals, we have best physicians, we have very great, brave nurses, okay? But we don't have best health coverage in Lebanon, because also we have this gap between the needs, the continuity for hospitals. Can you imagine now that hospitals and physicians are now, they started the first month, okay, war, okay, but till now they didn't receive any financial support, okay, because we don't have emergency plan at Ministry of Finance for this. It's one of things that unfortunately, as I said, we don't have this law who can manage the situation to make sure that everything is working as I needed in this situation. I think it's lessons for us. It's big lesson, okay. We are trying as members of parliament to teach this, to study in this situation. Sure, it's different between one region and another region. Sure, it makes I think more focused to public hospitals. In this situation, you need more public hospitals. Private is good, they are working good, but you can't give any patient to big hospitals, especially to expensive hospitals, okay? So in this case, you have, I think Dr. Firass Abiad started to push more these public hospitals, and he did a lot of for them, and I think Dr. Rakan also is continuing this. And the most important for us is to make lessons for the situation, and we are doing this. We are doing this, and the most important for us is also to try to have the universal health coverage, because it will make easier for people to manage their health in this situation like now, because a lot of people are suffering. I think at the end we'll continue to discuss these things with other ministers. We discuss this with president, with prime minister, okay, with other members of parliament. But as Dr. Nadine said, Dr. Firass said, I think in Lebanon all time is not easy to create policy, okay, to create protocols, okay. But the most important for me, after I have been working with war 96, 2000, 2006, 2024, and now, biggest problem that we don't have the law for disasters, for the emergency plan. Thank you.
Thank you, Dr. Abdullah. You highlighted really very important topics and issues that are usually surfaced in times of crisis. I'll go to Dr. Hussein, building on what Dr. Abdullah has just mentioned about factors that are not health-related. I would like to ask you, from where you sit at the WHO, how are you and agencies supporting local authorities in addressing underlying social and structural determinant of health alongside emergency needs? I mean,
yeah, sure.
From a legislation perspectives that Dr. Abdullah has just mentioned. First of all, is the WHO have the authority, between brackets, if we can put it this way, to support by any means local authorities in establishing new legislation to support humanitarian emergencies? And also, what about other social determinants of health? Thank you.
Yeah, so thank you very much for your question. So the first thing first, the WHO doesn't have the authority because we are not the regulatory authority in any member state. So we are a member state driven organization. Our role is more advisory. So we can advise our line ministry and also different ministries that what is the added value that will be included in the health sector or any other sector or the national priorities if they include, let's say, A, B, C, D, E. I can give you an excellent example that the government of Lebanon has been working on is the universal health coverage. So it's a law. So many countries approach this law differently because everybody looks at it that what is there for me, right? So it's a political choice. Sometimes it's a national and sovereign choice by the member states. So we always advise them that what is the added value. On top of this, that if I also look at the other UN agencies or the other humanitarian actors, what kind of benefit they bring. as we have already mentioned, that health cannot be addressed alone because it's a multi-sectoral thing. You always have nutrition involved within the health. Water, sanitation is heavily involved within the health determinants. And then you have the mental health and psychosocial conditions. So which is also intersectoral and cross-sectoral operations and the need of the beneficiaries. Last but not least is the social protection, because that is the most important component quite often that we forget, that if you don't have social safety, if you don't have social protection, ultimately it is going to impact your health and well-being, because health is not only about your healthy lifestyle or everything, it's also about your well-being. So all of them are interlinked to each other. And this is where different UN agencies, through their line ministries, they always advocate and they advise that what are the roles they can play, introducing some laws, regulations, and rules that introduce positive impact and positive benefit for the beneficiaries, which is the citizen of their nations. And then they have to reinforce the stewardship function, because any law is not a law if it is not nurtured and cared for a very long period of time, until and unless it is totally absorbed by the society. And then finally, I can give you an example in Lebanon, what we are currently doing with the Ministry of Public Health. It's about, in my previous response also, I mentioned that the visibility of the role of the government, visibility of the function of the Ministry of Public Health. So what we are doing, that not only in the national level, we have a subnational architecture, and that is led by the Raisal Maslaha. So these are the senior administrators from the Ministry of Public Health. They are sitting in the governor's office. So they bring all the partners on the ground, and they are connected on their local problems, because we always see that the local problems should also have a organic local solutions. And the nuances in Lebanon is quite diverse. So who are best suited to take this kind of decision? And when they engage with the diverse partners, you always address the issues of the water and sanitation, the social protection, the nutrition, and mental health. So these are the added benefit we include. So it is more like a decentralized leadership model where you involve different layers of the government, and the whole machinery works towards one common goal, which is the Vision 2030 for Lebanon. Thank you.
Thank you, Dr. Hussein. Basima, I'll hand over to you to continue.
Thank you, Dr. Slim. Dr. Abdullah, again, يعني thank you for your time allocated today. بعرف your busy schedule. It's always insightful to have such a discussion. I will address my question for you. وفeel free to answer كمان هيك in Arabic بطريقتك دايما السلسة So basically, as we know, Lebanon health system has been under sustained pressure يعني from different crises. على unfortunately يعني passing through يمكن financial crisis to COVID-19 to Beirut port explosion and the more recent war escalation. هلا you touch it in a way in your opinion you mentioned بالintervention تبعولك انه how other sector can better be integrated to support the health system performance. يعني برأيك what are the specific governance tool حضرتك you mentioned يمكن وزارة المالية or support من other financial resources to keep talent أو to keep people motivated and هيدا. So برأيك what are the specific tool beside the collaboration, interministerial collaboration or the decentralization maybe of decision making can help on the ground?
Thank you, Basima. It's my pleasure to be with you all the time. I know my English is not fluent, okay, but I will continue maybe in Arabic to explain
Pleasure.
better, okay? المشكلة باسمة مثل ما قلت لك ما في خطة على قاعدة قانون. في خطة وزارية، رئيس الوزراء عم بيحاولوا يعملوا شيء منظم بهالموضوع. بأكد لك إنه ما عم تطلع منظمة. أعطيكي مثل أو أمثلة لتعرفي شو اللي بقصد. لما أنت ما عندك أي رقابة جدية فعلية على الفود بروجرام، وأنت عم تعملي اليوم مطابخ عم تعطي لي 130,000 وجبة يوميا دون أي رقابة جدية، لأنه ما في يعني هي السلامة الغذائية عندنا ما تفعلت بعد، ما عندها جهاز. طيب ما أنت عندك أسبوعيا بالشيلترز فود بويزنينج، طب أنت منك مضطرة تفوتي بهالموضوع، عم تكلفك وجع راس ولبكة ومستشفيات وإلى آخره وإلى آخره وإلى آخره. هيدا مثل تاني، بدك تأمني مي، حتى تأمني صحة الناس بالشلترز بدك تأمني مي، مش هيك؟ ولا الهايجين ولا إلى آخره. للأسف بكتير مراكز عم بلش يطلع لنا سكيبيس وغير سكيبيس وإلى آخره. فللأسف هالموضوع عمل لك منه بلاند من قبل. ما عم نتعلم من تجاربنا إنه ما لازم يكون عندنا بس رياكشن على الديزاستر، يكون عندنا بلاننج قبل بوقت. بس هذا البلاننج بده له، ما عندنا قانون كوارث. نحن حسينا بنقص هذا القانون وقت الكورونا. بالكورونا ما عرفنا مين بده ياخذ قرار، يمنع العرس او ما بيمنع العرس، بيسمح بجنازه او بيسمح بجنازه. طلع بالقانون ما في حد عنده هالقرار. وهلا نفس الشيء عندنا المشكله. مين عنده القرار؟ فتح المدرسه كمركز ايواء. ما بخبرك شو تعذبنا اول اسبوع بهذا الموضوع. وزاره التربيه زدت على الاجهزه زدت على المحافظ على القائم مقام. بالاخر ياما مدارس خلعناها وفتنا فيها، يعني هي موضوع تاني. بس عمل لك ليه القصه اللي عم نحكي الميجر بروبلم عندنا انه ما عندنا قانون ينظم الكوارث، لانه الصحه هي نتيجه. انتبه، كل خطا باي مجال تاني، كهرباء، مي، اكل، كل التفاصيل تنعكس على صحه الناس. صحه الناس بتحط تكلفه زياده، اساسا ما عندك هالامكانيات انت. لذلك انا كنت عم بقول انه we need this law. sure we'll do this law, we are doing it. okay على الدسكشن هو عندنا هلا بالهيلث كوميتي. And I think also at the same time we have to يعني show that Lebanese are equal. Now Lebanese are not equal with health coverage. يعني الهيلث الببليك هيلث عندنا المينستر بتغطي شيء، السيكوريتي سوشيال بغطي شيء ثاني، الاجهزه الامنيه بتغطي شيء ثالث، مش هيك؟ تعاونيه شيء رابع. بس ديسبليست عم يجي ديسبليست عم بلاقي فيه اذا بدك ديسكريميشن له، في تمييز بين مستشفى ومستشفى كيف عم يتعاطوا معه بهالموضوع. لذلك هي التجارب عم ناخذها بعين الاعتبار. وعندنا مشكله اخيره انتبهوا لها كثير. الدكتور ابيض يعطيه العافيه اول واحد اشار ومعه حق، وسمعته بس عم بقول نحن مش لازم نكون على طول شاريتيز عم نشحت برا. مزبوط عم يحكي. من هيك كان اول واحد دخل على الموازنه، اوكي، على البادجت عم نحكي الجفرمنتال بادجت، حط موازنه للبرايمري هيلث كير واستمرينا فيها السنه كمان. اوكي بس وي نيد مور، بدها مصاري اكثر. لا لك ليه؟ نحن بالنهار يعني عندك من ال 8 morning ل 4 5 p.m. we don't have problem بالاي بالهوسبيتالز. ليه؟ لانه برايمري هيلث كيرز بيكونوا عم يشتغلوا. بعد ال 5 p.m. جربي روحي على مستشفى، ما حتلاقي محل، لانه سكروا البرايمري هيلث كير، صارت كل الناس بالشغلات الصغيره على المستشفى. So we didn't create اذا بدك system to keep this primary health care working also at night. We have to do that. Thank you. حاولت اختصرها.
Thanks a lot. لا أكيد shedding and again يعني putting الإصبع على الجرح. So just for the sake of time كمان my question will go to Dr. Bouarom. Based on your work experience and your exposure in a fragile and conflict affected setting, the humanitarian development and the peace nexus is widely endorsed. Yet in protracted crisis, it often remains more aspirational. And I think you touched it in a way during your presentation. In your opinion, what are the key structural and governance barriers that limit the implementation, and how this barrier can be addressed properly to support more resilient and integrated system? Thank you.
Thank you, Basima. I think the nexus itself, يعني humanitarian development peace nexus, remain a bit more rhetorical than operational because of many things. I don't know. We're running over time. I know. I will highlight some of the key challenges. I know things are better. So we heard today, but I know at regional level at WHO, EMRO, they have a lot of work to align humanitarian development. But let me start with talking that we're talking about different systems. Yani humanitarian system is really having its own structural issues. It's not fit for purpose anymore. We keep on saying we need to localize the responses. We need to give power to communities, and this still the power is with those who have the money. And بعده اللي عم يدفع هو اللي عنده more power than those who are receiving. So that's really some of the structures that are really still structure problem are still there. So in addition to this, أول وحدة different mandates معقول and humanitarian actors بهمهم السرعة بهمهم الاستجابة السريعة the speed, the parallel system, while the development is in different kind of a perspective. Peace, it's a different story. It's more political in many conflicts across the region. When is the time to think about peace? يعني let's take the example ناخذ سوريا. Did we move from the war time to the peace? Is it really the transition? It's not still all regions together getting back together. So that's a different story. I'm not the best person to answer that. And the second point is about financing structure. So we have still short term and humanitarian funding is still talking about 3 months project, 6 months. And Dr. Abdullah mentioned the needs are different on the ground. People are looking for something else. خصوصي local communities مثل ما حكيت بالpresentation. كتير بيضووا على at the international level at the refugee crisis. But when it comes to people that didn't cross international borders, بعضهم بنفس البلد. So it's really the case, unfortunately, sometimes it's a problem beyond the state itself. Well, of course, as colleagues mentioned, governance complexities. I'm giving مثل ما قلتي من غير settings. So in Palestine and other places, we have issues of not just fragmentation of governance, but contested authorities and so on. And the most important thing, is really kind of, as I said, not to forget that the nexus is not just technical. We have power structures, we have resource allocations. So it makes it really difficult to operationalize by itself. So systems are not really designed to merge. But again, examples are there to make things different. I'll stop here. I know we're running over time. Thanks.
Thank you for everybody intervention. I will hand it again to Dr. Rita. Thank you.
Yes, we're way over time, so
we're running out of time. Yes,
exactly. On behalf of the chapter, I want to thank everyone who joined, and I want to thank the speakers, the panelists. Thank you all. We're very much looking forward to hopefully stability again. We have a very ambitious program for the year as ISPOR. For you to stay in the loop, you can follow us on LinkedIn to make sure that you're up to date, and hopefully next time it will be in person. Thank you again, everyone, and see you in the next event.
Thank you so much.
Thank you very much.
you.